In terms of our presentation, I want to discuss the residency standards and the integrated guidance, give a very brief overview about the role of O&P residency from the perspective of the site, as well as the residents. We're going to go through the importance of standards and how they are structured, as that's going to relate back to successful applications. We're also going to go through residency sites and pathways to completing a residency, and minimum activity volumes, recruiting and advertising requirements, and last but not least, the responsibilities of the director and mentor. The big take-home picture here is the 2025 residency standards are truly an evolution in how O&P residency programs train orthotists and prosthetists. And although there are a considerable number of updates, O&P residency will continue to serve as the second half of the orthotist prosthetist education. One thing that I think you'll find helpful, not only with regard to operating the residency program, but certainly getting accredited, is the fact that guidance is integrated within the standards. We know that education and training standards are not always easy to understand or apply to real-world settings. So inline guidance statements have been integrated to give residency stakeholders, including directors, mentors, and even residents, jargon-free information about how to make the most of your application and ensure the program not only complies with the standards, but truly helps shape the future of the profession. Now, speaking of O&P residency from a broader construct, O&P residency provides real-world experiences with the goal of developing an independent, competent entry-level clinician. And it's this idea of independence that sets academic training, master's degree programs typically, different from residency programs. Developing that independent skill set is key. Furthermore, the term competency. We've had competency-based residency standards for some time, but I'm pleased to say that the competency framework's been updated. It's reflective of truly a modern clinical framework. And the other thing that I want to be candid about, and I'm not trying to offend any educators present, I'm an O&P educator myself, but O&P residency is arguably the most relevant component of a practitioner's education. And it's designed and intended to be a structured, immersive, real-world experience. And I assure you, structure is the cornerstone of the 2025 residency standards. In terms of residency stakeholders, there's really four major groups: the patient, the resident, the faculty, and NCOPE. And the patient has to be first. Remember, providing appropriate patient care is the ultimate goal of residency. The resident is a very close second. They're part learner, part employee, multitasker, and truly the future of our profession. But the faculty is really who this presentation is designed to benefit the most. Those residency directors and mentors and members of the patient care team that shape learning. This presentation is for you. And remember, you do have the responsibility of shaping learning. Because while NCOPE has standards and standards define minimum expectations, what really occurs day to day at your residency site is something that the directors and mentors need to be hands-on with. Now, in terms of residency standards and structure, keep in mind standards aren't suggestions, but they are a minimum set of requirements that must be met by the residency program stakeholders, and also demonstrate that there are adequate resources available at that residency site. And the 2025 residency standards consist of 5 sections and 4 appendices. And the integration of appendices is new versus our previous version. But these appendices allow NCOPE and our communities to update the standards more frequently. By using appendices, we can make sure that the clinical activities defined for residents are truly consistent with modern clinical practice. Now, in terms of residency program types versus residency sites, underneath the old residency standards, there was this idea that there were orthotic residencies and prosthetic residencies, and people could pursue what was called a single discipline orthotic residency or a single discipline prosthetic residency. But I want to be clear that under the new standards, those terms don't exist. Individuals are going to be required to demonstrate competence and meet all requirements in both orthotic and prosthetic disciplines in order to be considered complete by NCOPE. Now, that doesn't mean that residency sites that could only offer training in the practice of orthotics or the practice of orthotic prosthetics for that matter need to shut down. We very much could use your focused expertise in orthotic or prosthetic clinical practice. But residents are going to need to complete what's known as a two-site residency in order to actually engage and interact with residency sites that can only offer training in only orthotics or only prosthetics. For residency sites that can offer training in both O and P, that's wonderful. And you can offer what's known as a one-site residency, meaning that the resident is able to meet all requirements and demonstrate all required clinical skills and competencies at a single residency site. And I want to be clear, the term site doesn't talk about just one arbitrary building. A residency site refers to the one main clinic, as well as all of the nearby or even remote clinics that are aligned with that as well. So let's talk through some hypotheticals. I have individuals joining us today from a couple of really well-established hospital-based residency programs that have offered both an orthotic and a prosthetic residency in the past. So at the University of Michigan, for example, it was very common for a resident to pursue an orthotic residency there, complete a single discipline orthotic residency of no less than 12 months, at which point they were eligible to earn their certificate of completion if all requirements were met, and they become candidates for the orthotic simulation or CPM exams. That resident would then register for a prosthetic residency, do everything over again, and then ultimately get another certificate of completion, and subsequently be eligible to sit the prosthetic simulation and prosthetic CPM exams. Under the 2025 residency standards, it's important to recognize that the ABC exams are transitioning to combined simulation and combined CPM exams. And while NCOPE can't award a certificate of completion for someone after they've been trained in just orthotic practice or just prosthetic practice, it can be simplified. The University of Michigan, for example, again, they could have the resident register for a combined O&P residency. And that resident could focus on nothing but orthotic management for no less than 9 months. It could still be 12 months as it was previously, though. And then prosthetic management for no less than 9 months. But again, it could be as long as 12 months in that discipline. That resident would earn a single certificate of completion, and they'd be eligible for all of their ABC exams. And that's something that I'm frequently asked about by the various residency sites and stakeholders, because so combined O&P residency doesn't mean that the resident every single week needs to be doing orthotics and prosthetics 50% of their time in each discipline. No, that's how the old standards were structured. What we're looking at there on the center of this slide is perfectly acceptable. Let's talk a little bit more about structure, though. The current O&P residency structure for combined residency requires that the resident spend a minimum of 18 months focused in both orthotic and prosthetic management concurrently throughout the full duration of the residency. But what if a residency site wanted to focus on one discipline at a time, as I just illustrated on the last slide? That's okay too. I had another site reach out and go, Chris, I got a crazy idea. Could we do focused orthotic training for no less than 6 months, focused prosthetic training for no less than 6 months, and then a combined O&P residency for no less than 6 months? And the answer is absolutely. The new standards are quite flexible, and that might make more sense from a logistics standpoint, a patient standpoint, a location standpoint. And the other thing to keep in mind is accreditors define minimums. We mentioned that the minimum duration of a residency is 18 months, but it could be extended to 24 months or even longer. We have residency sites today that operate 24-month-long combined O&P residency. And those sites can continue to do that if they feel it would enable the resident to have training adequate to ensure that they're successful and capable clinicians. So on one of the previous slides, I talked a little bit about what's going to happen to the residency sites that maybe were centers for excellence in orthotic care or centers for excellence in prosthetic care. Those sites can continue. So let's work with some hypothetical clinics. Let's imagine there's a local practice nearby me in Chicago called Braceworks, and they focus purely on orthotic management. That resident would enter residency at Braceworks. They do their 12-month orthotic residency, get a certificate of completion, and now they could sit the ABC orthotic simulation and CPM exams. And then they could go to the prosthetic focus facility down the road. They'd register at that separate facility. They're both independently accredited. They'd earn another certificate of completion and then be eligible to sit their prosthetic boards. Under the 2025 NCOPE residency standards, it actually would look very similar. That resident would still register to enter a focused orthotic training phase at Braceworks, recognizing Braceworks doesn't have the prosthetic patients or population to enable training. That resident would wrap up their time there. They would demonstrate all required competencies, meet all minimum patient volumes, and they get a fist bump from that residency director and a good luck. Because unfortunately, there's no certificates of completion that can be granted under the 2025 standards for training in just one area of practice. So that resident would have to register to go to a facility that can offer prosthetic training. They go to the local prosthetic ninjas clinic, or they could even go to the local hanger clinic that always could do O&P. It's fine. So long as the site can offer training in prosthetic care, that's great. They finish their training in prosthetic care, spending no less than 9 months in that area. And then they would get their single certificate of completion and become eligible for both the simulation and CPM exams, which are combined. But here's the kicker. Braceworks and Prosthetic Ninjas, I mentioned that hypothetically they were in the same neighborhood, but they don't need to be affiliated in any way, shape, or form. Let's talk about real-world examples. Larry Jones Memorial Hospital, Chicago, has a rich history of orthotic residency, and Martin Bionics in Oklahoma City has been training prosthetic residents exclusively for many years as well. That resident could do their training at both Larry Children's and Martin Bionics. They get a single certificate of completion with both of those residency sites' names listed without the residency director at either site ever even having met. Now, residency sites must define rotations and structure. This is the big one. The residency program needs to identify not just the duration. Is it going to be a minimum of 18 months or a minimum of 24 months? You have to put this on the application. You can't just decide how long it's going to be for each individual resident. And then you're going to identify rotations, and it could be based on patient populations or maybe specific mentors. For example, in the first quarter, you could say we're going to focus on adult orthotic care with Carl. Second quarter, we'll do pediatrics with Carla. Third quarter, we're going to focus on adult and geriatric lower limb prosthetics with Carlito. Upper limb prosthetic care is going to be with Carlton during the first quarter. Fifth quarter, that's when we do Pete's prosthetics with Karen. And during the sixth quarter, multiple limb loss, high activity prosthetics and orthotics with Carney. Great. We can define it by the mentor, by the patient population, or heck, days of the week. At the bottom, I actually have a structure that is used by the local hanger system here. So during the first quarter, Monday, Wednesday, Fridays, they report to the Oak Park Clinic. And Tuesday, Thursdays, Westchester. They're both suburban outpatient practices, but with very different patient populations. And then during the second quarter, Mondays, they go to La Rabida Children's Hospital. But Tuesday through Friday, they go to the adult acute care hospital known as Rush. Quarter three, Monday through Friday, they go to the exact same office. Lincoln Park is an outpatient facility, and there's no need to go anywhere else because Monday through Friday will keep them plenty busy. I think you get the point, though. You could define it by locations, mentors, patient populations. We have moves. But the big thing to take home from this slide is this is truly the level of depth that NCOPE is looking for from residency directors. It does not need to be elaborate. We just need to know, what do you want the resident to be doing during 18 months of their life? Give us 3 lines of text so we at least can have that resident know how are things going to shake out for 18 to 24 months of their life. And you also might be going, Chris, I get it. You don't need a lot of detail. Like, do you have templates? Of course we do. As a matter of fact, it's linked in the application as well. So that URL posted right there, it's a nice Excel document that you can use to figure out, am I going to map it by mentors, populations, locations? It's flexible. You do what works well for you and your clinic. NCOPE just wants to know what's the plan. So in terms of balancing patient care, I talked a little bit about this earlier. There is this whole idea that a combined O&P residency under the old standards, if you will, the standards that are being grandfathered out, that the residents spend ideally 50% of their time focused on orthotic care and 50% of their time engaged in prosthetic care. That's great, but it's not reality. If I were to actually ask the audience, raise your hand if you spend exactly half your time in orthotic care and half your time in prosthetic care, and I'd be lucky if I got past one hand. Very few clinicians actually have this 50-50 time split. So NCOPE decided that perhaps time wasn't a good measure. We're adopting what's known as MAVs, or minimum activity volumes, and I'll talk about that in a little bit more depth on the next few slides. But minimum activity volumes allow NCOPE to define specific visit types, patient populations, and interventions. So we can actually ask and answer the one question that we're usually prompted with on a weekly basis. How many AFOs does this resident really need to see? We're going to give you a number for the first time ever because we have data to support it. The key here, though, is these minimum activity volumes. It doesn't just have to be visits where the resident is working independently. We're actually worried about the resident getting enough exposures at the observation or even the assist level. And for a little bit of context, we know there's challenges basing residency on time in the first place. NCOPE Tracker, first of all, doesn't even log time. And we know for a fact, direct patient care, if we take a look at the average resident, they only are patient-facing about 53% of the time. Then they're in the back doing technical procedures or documentation, billing, and coding, pretty close to about 20% of their time each. 7% of their time, they're doing things like case studies. And 5% of the time, that kind of falls into other. Maybe they're doing inventory. There's all sorts of things they could be doing. One thing to keep in mind, though, is there does need to be a progressive increase in resident autonomy. Well, I know some of you on this call are like, Chris, I got thrown into the pool for my residency. There's either sink or swim, and I swam because I got CPO after my name. That's great, but that's not really a very pragmatic approach or an approach conducive to learning in a clinical setting these days. So it's important that the resident actually get comfortable and foster independence and have confidence before you have them start working towards that level of independence. And also, as an EBC certified practitioner, ethically and morally, you want to make sure you're providing the patients with appropriate care. Now let's talk a little bit about MAVs, minimum activity volumes. Minimum activity volumes are achieved by a combination of visits where the resident observes, assists, and or independently performs patient care. And if you're thinking, Chris, where are these numbers coming from? Like, what do you mean by activities? A single office visit counts as an activity. So for context, a patient with a unilateral transtibial amputation is first seen for their initial eval at week 1, and they get their shrinker, and we try to get that limb volume stabilized a little bit, and then at week 2. Then they're casted for their definitive prosthesis. We already have 2 activities done. The eval was activity 1, the casting was activity 2. The resident then does a test socket fitting at week 3. Now we're up to 3 activities. And a week after that, the patient gets their delivery of their definitive prosthesis. Now we're at 4 activities, plus those patients need follow-up. So 1 week out, they're going to have their first follow-up. That's 5 activities. So the example I just provided, a single transtibial patient, that counts as 5 activities. And the best part, logging patient encounters for the residents is no different. The way that we calculate minimum activity volumes, we already have the data captured in NCOPE Tracker anyway. So the residents, they're going to log the way they always have. And let's talk a little bit about those minimum activity volumes by visit types and demographics. For example, orthotic evals. That resident must have at least 50 orthotic evaluation visits logged as a resident, but they only need 35 for prosthetic. On that note, diagnostic fittings. Well, I like a good old test orthosis. They don't need to have any test fittings for orthoses, but they better have a minimum of 35 test sockets for prosthetic cases. Furthermore, follow-up. We know for a fact follow-up's a much bigger component of prosthetic care. So you need to have a minimum of 45 follow-up visits during the course of the residency for orthotics. They only need 35. The other big paradigm shift, prosthetic patient care is no longer required for pediatric patients. Under the previous residency standards, if there was one thing where residency sites said, Chris, I don't see peds cases in our office. There's a Shriners up the road. So PEDS prosthetic experience, if your facility has it, awesome. Keep giving residents that experience. But it's not a requirement, recognizing that not a lot of facilities have access. So what about specific orthoses like AFOs and FOs? Over the course of the residency, the resident must have a total of 50 AFO visits, and they need to be independent in at least 25 of those. The other 25 visits, they can be at the level of observe assist or independent. Foot orthoses, very common for residents. They get at least 25 FO visits logged, not patients, visits. And of those visits, 15 of those need to be independent. KAFOs, this one's a little different. You notice that they don't have to be independent for any KAFO visits, but they do need to assist with a minimum of 5. And they need to actually observe, assist, or independently provide care for another 5, having 10 total KAFO visits. LSO, TLSO, wrist hand orthoses, the resident must have at least 5 independent visits for each one of those interventions, and 10 total where they either observe, assist, or independently provide that service. There's also electives. Now, we talked about children's hospitals and centers for pediatric excellence. That's a great place to see things like clubfoot orthoses or SMOs. The VA, they don't see an awful lot of those. But the VA does, however, see a lot of knee orthoses and diabetic shoes and inserts. And NCOPE wants to support residency sites in a wide variety of settings. You can learn a lot at a VA or a children's hospital for that matter. So, with our electives model, the resident must have at least 30 visits with any of the 6 orthoses on the left-hand side. They need to see at least 3 different orthoses from that list, and they have to provide independent care at least 25 visits for those 3 specific orthoses. If they see all 6, great. I know clinics that do all of the above. But do the residents need to see all 6 of those? No, they just have to see at least 3 of them. And for the volumes, defined on the right. What about spinal? Scoliosis orthoses, you'll notice, are an elective. And there's, again, patient and parent preference sometimes drives children to not go to just the local O&P clinic, but the Pediatric Center for Excellence. So scoliosis orthoses and cranial molding orthoses, those are electives. But also, if you're at the VA, you're probably going to see orthopedic conditions that require cervical collars, or shoulder, elbow, wrist, hand orthoses, or humeral fracture orthoses. They both have a place. And with the upper limb and spinal electives, the resident must see at least 3 of those 6 interventions independently for a minimum of 15 times and a total of 25. So they better have at least 10 more observer assists across that list of orthoses. And what about prosthetic care? Minimum activity volume for transtibial, that is 60, where the resident actually is independent, and at least 40 of those transtibial office visits. Transfemoral, the minimum number of visits is 45, where the resident is acting independently, and at least 25. There's also lower limb electives, and on the left-hand side, you see we have 5 specific levels: partial foot, sides, knee dysartic, hip dysartic, as well as EFFD, and this includes things like rotation plasty. The resident should see at least 3 of those respective levels for prosthetic management and be independent in at least 10 of the visits, and have seen at least a total of 25 of those items. Post-op care is also alive and well, and we recognize post-op preferences are largely geographic. If you happen to be in the Phoenix, Scottsdale area, you might actually see eye pops. That's the only part of the country I've ever seen a resident document one. On that note, if you're not in Phoenix or Scottsdale, I bet you're seeing shrinkers or RRDs. The resident needs to be involved in at least 10 visits where one of those 3 postoperative interventions is being provided, and they need to be independent at least 5 of those visits. Furthermore, upper limb. Upper limb is an area where not a lot of residents are really acting all that independent. So the residents aren't required to have any office visits for upper limb prosthetic patients where they are the primary independent treating clinician. But they do need to assist with at least 10 of them and be involved with at least 20 separate upper limb prosthetic visits. And if you're thinking, okay, I'm doing the math in my head, like these numbers seem high, where are they coming from? These numbers, interestingly enough, are based on the 5th percentile. That means 95% of residency sites see more than this. And when we ran those numbers, We removed places like the University of Michigan and UCSF and multinational companies that may be based out of Germany. We looked at small to medium businesses, and those are how we base those minimum activity volumes. These numbers are realistic for 95% of residency sites. Another question we're often asked is, what does NCOPE think about fabrication? Supportive of it? And the answer is absolutely. There are 7 competencies in the new residency standards that are tied to psychomotor skills and fabrication. And the new standards, they don't restrict the amount of time that a resident spends performing those technical procedures. But I want to be clear, having a large volume of technical fabrication opportunities doesn't change those minimum activity volumes. And on the previous few slides where I was talking about office visits, you don't log time in the CFAB laminating sockets. That's not a patient visit. NCOPE Tracker hasn't included any of those fabrication activities. And one thing that we did notice when we looked at the data, I can tell you that clinical sites that have minimal fabrication requirements, they do not yield persons less likely to pass their board exams. I do have residency sites that had fairly low number of patient encounters, numbers below where those MABs were set. And those individuals were less likely to have the letter CPO after their name. Now, when you fill out the application, this is actually a screenshot of the application, we're going to ask for the minimum number of activities that you can guarantee at the levels of observe, assist, and perform. And when you fill this out, this is your chance to actually say, we believe we can give that resident a minimum of 45 independent AFO visits, and they're going to be able to assist in at least another 10. But beyond that, for my residency sites that are renewing, and I have a lot of seasoned residency directors on this call now, we also have NCOPE Tracker data, and we're going to use that data to figure out, can residents hit the MAVs at your site? Now, if you're at a new site and you haven't had residents recently, you're at a clinic that just opened up a few years ago, and you're like, well, we don't have any NCOPE Tracker data. What do we do? You're going to be prompted to upload a PHI redacted report of patient visits that demonstrate access to all of the populations and interventions. So that report needs to actually identify not just AFOs, but transfemoral, transtibial, partial foot and cymes. We need to make sure that once we pull the PHI out, that report shows this site actually sees enough patients that they can theoretically meet the minimum activity volumes. And for my residency directors who may be panicking going, I don't think my residents logged all their cases in Tracker. I had that one resident, I know he was trouble. They probably weren't trouble, but residency sites that are renewing are also welcome to upload a PHI redacted report from your EMR as well, should you feel that the NCOPE Tracker data submitted by your resident isn't the most accurate. It's okay. Now, beyond that, policies and procedures. NCOPE has its own policy and procedure manual, but within the residency standard, standard 2 of the NCOPE residency standards focuses on program requirements and policies. And it's going to ask for residency sites to define how much time off does the resident get? And if the resident sits their combined written exam, do they have to use their personal time off bank, or does the company just let them go and sit the test? It also requires that the sites be more transparent. Things like travel requirements and health insurance, and what are the work hours? And is a resident required to take on call? Furthermore, what's the internal complaint process? And this will actually likely be standardized in many ways based on facility accreditation. You also need to identify things like your clinical partners. If you are the VA and you're offering training in both O&P, you still need to have affiliates somewhere that can enable those VA residents to see pediatric orthotic cases. Where are they going to go? That's information that you have to tell NCOPE and also share in your advertisements as well. But a lot of these policies, I'd wager they already exist for many of the companies on this presentation now. For those of you even watching it recorded, you likely had to provide this information to get facility accreditation. The other piece of the puzzle, if you don't have these policies, we've actually been building out a pretty thorough database of samples and templates that you can use. Now, the resident needs orientation as well as undergoing things like HIPAA training, safety and universal precautions, as well as organizational policies. And NCOPE, we're going to ask for a copy of that orientation training schedule. Now, some things that are a little bit different. A single person can have the title of director. And I recognize there's some residency sites that have as many as 3 directors. If you have 3 directors before, you still could have 3 folks serve in the capacity of director, but one person gets the title of residency director. Think of it like a totem pole. There can only be one owl at the top, but we allow for associate directors. But at the end of the day, you want one person to be accountable overall for the program's success. Furthermore, based on feedback we got from the residents, we need the director or associate director to be active in the feedback process. Now, if you're a small or medium business, odds are you're not just the director, you're the mentor. The resident works with you predominantly as well. You also might be the lead technician and the chief human resource officer. That's okay too. But there are residency sites where the residency director isn't even in the same time zone. Bionic Orthotics and Prosthetics has a pretty expansive network of residency sites, and that's great. The director, Jeff, he lives in the Chicagoland area. Does he go down to San Antonio for every evaluation? No, and he doesn't need to go to San Antonio. But every time a resident in San Antonio does their quarterly eval, Jeff should plan to hop on Zoom or Teams and be involved with that process. Because one of the complaints we did get from recent residents is, I'm not sure my director knows what's really going on with me and my residency program. So the director, they need to be involved. And if you're at a site with a director and a couple associate directors, those associate directors are appropriate as well. Speaking of directors and mentors, supervision of the resident may only occur for a director or mentor that meets the requirements in the disciplines that they're certified. So you don't want to have a certified prosthetist supervising the resident for orthotic services. That's pretty straightforward. But we did change things up a little bit. If you look at these 2 columns, the requirements for the director and mentor, they're identical, with the exception of post-certification experience and licensure. The director now only needs 4 years of post-certification experience and licensure, and the mentor, they only need 2 years of post-certification license experience. We've actually taken that bar and shifted it downward slightly, but there's a pretty good reason. When we actually looked at the residents' feedback on the overall effectiveness of mentors, it turns out mentors that actually were certified for less time, who underwent a master's program and did their residency fairly recently, they actually were rated higher than their mentors who maybe had 30 years of experience, but didn't need residency back when they went through. Another thing to keep in mind, online development courses. We are updating them actively, but online development courses must be completed every 3 years to make sure that director is up to date. Don't worry though, we'll have a refresher course that's not the full 3.5 hours. So if you've done the old course, but you just need the updates, we could probably knock it out in 1.5 hours. Now, in terms of what makes up a residency site, this is one of the other big paradigm shifts. Previously, NCOPE had this term for affiliate sites, and whether it was a clinic that you owned and operated and tied to the main facility, or was a clinic that was owned and operated by another company, we called them affiliates. And they had a 75-mile radius. But when we talked to residents, they said, Chris, 75 miles in LA is really rough. 75 miles in LA might be 4 hours in the car if you have to take the 5. So we've narrowed that radius down. So it's a 50-mile radius for what we now call satellite and partner clinics. A satellite clinic is owned and operated by the same organization as the primary facility. So in Chicagoland, we have several hangar clinics that participate in a residency program. And the main residency site that's located in Lincoln Park, and they have another site located in Oak Park, the very nearby suburb. That Oak Park clinic is considered a local satellite. Now, what about partner clinics? What's a partner clinic? That's a clinic not owned and operated by the same organization. The VA in Chicago, where I happen to be, the VA within Chicagoland, they don't have very good pediatric access, but they have a wonderful relationship with our local children's hospital. And our local children's hospital, which is about 12 miles away, is a local partner clinic with the VA hospital, and they're within that 50-mile radius. And for my residency sites that are thinking, wait a sec, Chris, I get LA is busy, Chicago traffic stink. I'm in Arkansas. Like, what about Jonesboro, Arkansas? 50 miles, really? No, we're okay expanding the radius. If you're in a designated rural area, And CMS actually has an application you can go to where you just click on a link, type in the address, and it'll tell you, you are in fact in a rural area. We're fine with that. We'll expand that radius to 75 miles and beyond that. At a couple of clinics, say, Chris, we have a facility that really does some amazing training, and they focus their training on upper limb prosthetic care. And we send the residents there for like 10 days a year just to immerse them in upper limb. But they're way more than 75 miles away. Is that okay? Sure. We just have a new term for it. So remote satellite and partner clinics are beyond that 50-mile radius, or 75 miles if you're in a rural area. And you can have residents report to these remote satellite or partner clinics up to 2 weeks a year. Actually, you could even have them report longer. We have one clinic that said, what if we were to do a residency where every 6 months, the resident moves to a new part of the country? They start in Philly for 6 months, then they go to St. Louis for 6 months, and they go to Detroit for 6 months, and they finish in Atlanta for 6 months. Is that okay? Yes. And I know that's more than 2 weeks. You just have to be transparent and tell the resident when they're applying and you offer them the job. You need to move every 6 months, and finding housing, that's your responsibility too. So NCOPE supports a lot of different structures and approaches. The residency site just needs to be transparent. We don't want a situation where the resident's been at a facility, let's say 6 months, and you say, we need to move 700 miles away right now. We didn't tell you about that when we first hired you, but you got to move. That's not okay. So remote partners and satellites, they weren't even a possibility under the old standards. You had to be nearby. We've changed that. Now we look for information about residency sites. We're going to be looking for things like, what's the mailing address? Who's the facility accreditor? Is it ABC, BOC, or in Texas? Maybe it's the Texas Licensing Board. We'll look at them as well. We need to know the facility's phone number and when the facility accreditation expires. And for the satellite sites, we just need to know those addresses as well and who's the primary mentor at the satellite or partner clinic. So the clinics where the residents are going to be sent to that are different than where maybe the director is. We just got to know who's going to be the person watching them at that location. And furthermore, let's say it's a partnership. Let's say that we have a VA and a children's hospital partner. Those are two different tax IDs. Show us the agreement between those two organizations that says residents are allowed to come through here and touch patients, etc. And earlier on, I talked a little bit about, well, what if I'm rural? How's that work? If you go to the website linked there and type in the address, 1437 Parkview Drive in Twin Falls, Idaho, you'll actually find a long-established NCOPE residency site there. And although Twin Falls actually is kind of busy, it's a growing city by a lot of definitions, it's technically rural. We're also going to ask, though, what's the distance from the primary site? So you may need to pull out Google Maps for that. It's okay, though. We got links for that as well. And speaking of those affiliation agreements or consortiums where the Children's Hospital and the VA get along, residency sites often ask the NCOPE staff, do you have a copy of one of those agreements or contracts? And we can at least give you some starter boilerplate to get things going, but make sure that your legal team and the legal team of whoever you do partner with is comfortable with that document. On that note, wow, we covered an awful lot of material very quickly, but I appreciate everybody being patient with me on kicking things off. Thank you so much for joining us today. Beyond the links that are provided throughout this presentation, please don't hesitate to reach out to the NCOPE staff, either myself personally at the email address listed on the screen, or residency@ncope.org. Have a wonderful day.